Hey guys, and welcome back to Clinical Physio with me, Phil Richards. In today's video, we're going to be talking about testing passive range of motion of the hip joint. So the purpose of testing passive range of motion is to see what happens when the active contractile element is taken out of the equation. If you're not familiar with why we test passive range of motion, we suggest you check out our video titled Why Test Passive Range of Motion for the full clinical reasoning process behind why we do what we do. So as to not slow your video down, we're not going to be comparing the left and right hips. But of course, in practice, we always want you to compare both sides to inform your patient diagnosis. So when we're thinking about testing passive range of motion, we need to think about three things. That's pain, range, and end feel. Right, that's it. Let's get into our main video. Let's get clinical. So let's quickly go through certain assumptions we can draw with regards to pain location in the hip and what pathology it might be. So you're instantly thinking about what this could potentially be when your patient comes in, instead of thinking, oh, panic, 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 what am I going to get through? So for instance, let's break this down so we can make it nice and simple. If someone has anterior groin pain, or as a hierarchy of thought, we're going to think it's more likely to be hip, less likely to be SIJ, and even less likely to be lumbar spine. And if we were thinking of the hip, we would be thinking of something like arthritic change, impingement, or less likely but still very prevalent, some sort of hip flexor tendinopathy. If the patient had a complaint of pain in the groin and it was very much more midline at the top, we would be probably thinking adductor tendinopathy. So that would be your main ones for the anterior aspect. With regards to the lateral aspect, time and time again, people will start to point around the greater trochanter, and instantly you'll be thinking, greater trochanteric pain syndrome, which can be a referral from the hip joint, or likely to be an abductor tendinopathy. So there will be your main ones thinking there. It could also be the deep stabilizing muscles of the hip, but we're still thinking hip. You are less likely to see a lumbar spine or an SIJ referral into the lateral aspect like that in isolation. Posteriorly, we'll be thinking more about lumbar spine, still the hip joint, and more likely SIJ in this instance relative to the anterior aspect. And they're the things you want to keep in mind as soon as they say, I have pain here or here or here. So now we're going to do our passive range of motion testing of the hip into flexion. So as a therapist, we're going to stand on the side of the leg being tested, and our patient is going to be in the supine position. Handling, what do we do? So with one hand, we're going to scoop under the knee, the posterior aspect, so behind the knee. The other hand is going to scoop under the calcaneus. From here, we're going to keep our back up straight, we're going to bend our knees, and we're going to drive the knee up so we can achieve flexion. If we're allowed to go past this point because we haven't provocated symptoms, etc., and our patient allows us to, we then want to swap our hands so we can complete the rest of the flexion testing. So what we're going to do is roll our hands off to the side of the knee so we're not causing excess compression here. And we're going to just take our body weight forwards and apply the passive motion there. So two really important things to do when you're doing this. As you come up, you don't want to be looking at a camera at home. You want to be looking at your patient's face the whole time, because this is highly likely to cause discomfort in the anterior aspect of the hip in a lot of people. So you want to be looking for signs of that. The other thing you want to do is be feeling intrinsically with your soft hands, that we talked about before in our handling, is what's happening at the hip. Because as you come up, there's going to be a point where the hip joint stops moving because it's reached its end range, and the ilium starts moving as you come further and further up. And if you're very, very soft, and depending on how stiff or not stiff your patient is, for instance, you'll be able to feel it. You'll feel like, okay, that's the end of the hip joint. I can feel that now. And the rest of the rolling is going to be from that ilium aspect. So let's talk about our pain, range, and end feel. So with regards to pain provocation, what could be happening? Well, what we know is as we're bringing the hip up into flexion, we're causing compression. And the compression is going to come around in two key areas. One is going to be intra-articular, which means we might be pointed towards an osteoarthritis, or potentially some sort of labrum damage or something internalized in the hip. The other type of area that we're going to get compression is the anterior aspect, so on the front, and that could come about from a femoral acetabular impingement. With regards to the range, we're thinking 135 degrees. So if I take this hip up and I follow to the end range, that would be about there. You may find actually as you keep going, you're able to bring the knee up a lot more. And that's because the ilium is going to join in at the end range, which brings us perfectly onto end feel. So if we go past the hip joint, which we would anyway in practice, bearing it in mind, and get to the end range, you're going to find it's either going to be a soft tissue approximation because their thigh is just coming up to their chest, or it's going to be a soft end feel as we're stretching the buttock tissue or the lumbar tissue. But what happens if we don't have a normal end feel? Well, the classic ones we'd get with that is a hard end feel here, and that is likely to make us instantly think of an osteoarthritic condition. The other time you can get a hard end feel is with the acetabular impingement, and because it becomes so painful and so tight in here, the ilium is quite reluctant to load and move anyway, so you won't get this sort of gliding nice effect. And that's something really useful to bear in mind. So if you're doing a passive test here and you feel, oh, this ilium doesn't roll up, I can feel I've got the end of the hip and this doesn't roll up, but it does on the other side, this may guide you to overactivity in the anterior hip muscles. So now we're going to test a passive range of movement of the hip into internal rotation. So as a therapist, we're going to be standing on the same side of the hip being tested. A patient is going to be supine. We're going to start by bringing the hip into a 90 degrees flexion position. This is the starting point. From here, our handling is as so. We're going to have one hand just above the malleoli on the inside, the medial aspect, and then we're going to have the other hand supporting the knee on the lateral aspect. We're being soft hands on the knee, no grippy fingers, please. So what we're going to do from here is we're going to turn our body and guide the patient's hip into internal rotation. So let's think about our pain, range, and end feel. In terms of pain, as we bring the patient into this internal rotation, we know that we're going to be causing a lot of compression on the joint. So it's unsurprising then that anything irritated within the joint can reproduce pain. So we'd be thinking about osteoarthritis. We know that osteoarthritis for the hip often involves the capsular pattern medial rotation, so they lose a lot of medial rotation. And we also can think about anything within the hip that's not linked to arthritis, such as a labral tear, because we're causing a lot of compression in there, that could be irritated too. Because we're moving the joint, our pain referrals can be anterior, lateral or posterior, but most commonly in clinic we'll see the pain anteriorly, secondary would be lateral and more rarely posteriorly. So they're the ones to do with the joint. You can also find with like a hip flexor tendinopathy or even a contribution from the adductors if there's a tendinopathy there, but this twisting motion will irritate the fibers if they're already inflamed, and that can be a source of pain too. In terms of our range, we're looking for around 45 degrees if you're looking at the textbooks and the literature. However, in clinic, we see the range more to be around, I would say, 25, 30 degrees. Not as extreme as 45. In the hypermobile patients, I'll certainly see around then. But we also have to take into account the congenital femoral rotation you see variance between patients. So some people may just naturally be able to achieve more internal rotation or external rotation relative to others. And with regards to the end feel, you're looking for an elastic end feel. It's not going to be super soft and it's not going to be hard. It's going to be that somewhere sort of, it does have a boing to it, as it were. If you have your osteoarthritic patient, however, it's going to feel very definitively hard. So keep your hands soft, and as you do it, you're really going to be able to feel that. It'll be a very, very good clinical clue that that's the presentation of osteoarthritis. So let's look at passive range of movement testing of the hip into external rotation. So as the therapist, we're going to stand on the same side of the hip being tested. Our patient is going to be in the supine position. We're going to start the test from 90 degrees hip flexion. So we ask the patient to bring their knee up towards their chest and we guide them to this position. From here, our handling is going to be as so. So one hand is going to come just above the lateral malleolus to secure that part, and the other hand is going to just be resting around the knee. From here, we're going to guide the hip into that external rotation, lateral rotation, and we can also just turn our body so we're not twisting and moving badly and apply our passive movement there. So if we think about our pain and our range and end feel. So with regards to pain, there's going to be a couple of sites of pain. The main ones will be anterior and lateral, and this could be from the hip itself. So not as common with osteoarthritis, but really anything intra-articular in the joint could be irritated from this. So it's not arthritis, but at the same time, we have to think in our heads it could be an intra-articular problem. If, however, the pain just refers specifically to the outside, this could either be from the hip or greater trochanteric pain syndrome from an abductor tendinopathy. That's going to be the most common thing you see. A classic one people love to talk about is the piriformis syndrome. So as we laterally rotate here, we can get compression on the sciatic nerve, which lives posteriorly. And we can test piriformis a little bit further by bringing the hip up into more flexion before we laterally rotate. If you do get that reproduced pain from that, it's going to be more posteriorly, potentially referring down the leg if we're thinking of sciatic nerve irritation. But please bear in mind that piriformis syndrome is definitely overdiagnosed in our opinion a lot. So even though you may have the presence of it, please check the history in your other parts of your exam to make sure it's not a downward ripple effect from something happening at the lumbar spine. Otherwise, potentially the ramifications for that are you're constantly winding up to try and stretch out a sciatic nerve that's not even being irritated locally, it's from a different place, which means you can potentially put your patient through weeks and weeks of discomfort for no reason if you looked into it a little bit more deeply. So if we think about the range, well, classically in the textbooks, they'll talk about it being sort of 45 degrees, but I'm sure you can probably see as I externally rotate Polly's leg here, the hip, that's a lot more than 45 degrees. Now granted, Polly's a bit hypermobile, but still, I would expect to see a little bit more in a healthy hip for external rotation. So just bear that in mind that actually a 45-degree angle may not be sufficient, but it helps you build your clinical picture. In terms of your end feel, this is going to be more of an elastic end feel. And one of the reasons it's going to feel elastic is not just from the hip, but once the hip has already locked itself in place, you're going to get an elastic end feel slightly from the lateral aspect of the knee that's involved. But needless to say, if you have very much a progressive arthritic condition, it's going to feel definitively a lot harder, and you will be able to feel that as long as you keep your hands soft, you're going to think, wow, that's definitely blocked. And that can really help your clinical diagnosis of osteoarthritis. So now we're going to go through passive range of motion testing for the hip joint into adduction. So as a therapist, we're going to stand on the same side of the hip being tested. Our patient is going to be supine. So the setup for this is we need the non-testing leg out of the way for this. So there's a couple of ways you can do this. One is to ask the patient to just cross this leg over so it's out of the way. If they're unable to do this, you can ask them to actively just hold their knee up. Because in this version, we're going to be passively moving it, it's okay for them to actively control the contraction if there's no better way of you completing the test. Some information is better than no information. So because we know Polly can do this just fine, we're going to get the leg out the way there. Handling. One hand is going to be just above the lateral malleolus, gripping like so. Our other hand is going to come and stabilize on the pelvis. From here, we're going to get ourselves into a bit of a stance and we're going to guide the leg into adduction. Now, hopefully, I'm going to see if I can do this okay for you at home. I'm going to show you what happens if the stabilization here is really, really poor. So if I just have a token gesture of my hand here, what you're going to find is there's rolling, there's hip hiking. I haven't really sort of seen what the hip can do in terms of its pure adduction movement. So you're going to need to put a reasonable amount of firm pressure on here, nothing that causes pinching or discomfort, but it's going to need to be a reasonable amount. The other thing that will do is it will really give you a better appreciation for the feel of the lateral aspect of the hip and the tensioning that occurs through it. So let's think about our pain, our range, and our end feel. So with regards to pain, the main one you want to think about is your greater trochanteric pain syndrome region, particularly with reference to a gluteal tendinopathy. And that's because as we are pulling through this way into adduction, this is being lengthened out. So if we have a lot of acute inflammation here, this is going to kick off a lot of nociception and cause the patient pain. To do with inside the joint, there is not as much provocation as there would be with, for instance, flexion or medial rotation. So you're not going to be looking at this as a key component for diagnosing something osteoarthritic or any other sort of intra-articular structure. But of course, anything you find could support your hypothesis later. To do with range, we're expecting the range to be 25 degrees. The end feel is going to be elastic. And this is because it's going to be the soft tissues on the outside that are going to be under stretch rather than any sort of bony articulation stopping further movement. What it can tell you is not so much anything like a capsular pattern per se, but if someone's particularly tight or hypertonic, you're going to be able to feel that in terms of whether it's really hard elastic or more of a softer elastic. And it's more of an elastic feel that you're feeling for. So now we're going to be testing passive range of movement of the hip into abduction. So as a therapist, we're going to stand on the same side of the hip being tested, and our patient is going to be supine. From here, we're going to need to take the leg out into abduction. So how do we do that? We're going to get one hand to scoop on the inside above the medial malleolus and just grip in here. And the other hand is going to come onto the hip to stabilize the pelvis. From here, what we're going to do is just progressively walk the leg further and further out. So you can see what's happening at home. I'm just going to take my hand away from here. Or in fact, on the subject, sometimes when you have a larger patient, it can be quite cumbersome to have your hand over here. And if that's the case, what you can do is actually just take the whole leg itself and guide it out this way, which is also an alternative version to doing it. But as you can probably see there, you will see some rise of the pelvis as you're not able to stabilize it. So it's a bit of a trade-off, but it depends on the situation. So let's think about our pain, range, and end feel. In terms of pain, well, as we're lengthening adductors, if we have an irritable adductor, like an adductor tendinopathy, that could be a source of pain. So we're thinking more medial groin or somewhere along the adductor path. The other common one is the gluteal tendinopathy from the gluteus medius minimus, anything around the greater trochanter really. And the reason for that is, one, we will be causing a bit of compression at the hip if it's a pure abduction movement and we come out far enough. So you can get this sort of pinching effect that can refer pain. But the other thing to do with a gluteal tendinopathy here is the muscles find it very, very difficult to switch off. So even though it's supposed to be a movement where there's no active movement involved, the patient will still be moving a little bit. And they may be co-contracting here, either because they can't help but join in, or because the muscle itself will refuse to let go. And as the movement occurs, this is supposed to be relaxing and not joining in. And they're the main two things you want to think about with regards to abduction. With regards to the range, you're expecting around 40 degrees in the textbooks. Personally, from testing this on hundreds of people, I would expect it to be more in the 50 range. Something to also bear in mind with regards to the range is you will of course get a lot more range as you come out if you allow the leg to laterally rotate. The position of the femur is going to be different and there's a lot more movement. If we just show you here, we can see how much further we can come out relatively to if we keep it fixed in to here. I've already reached my end point, but from here if I turn out, I've got a lot more freedom. So try and be strict with your testing when you do that, or use it as an experimentation process to compare what it's like in different positions. For your end feel, it's going to be an elastic end feel, because this is going to be the lengthening and the catching of the adductors. If you have someone that's very, very flexible, it's then going to be due to the hip where it articulates, it's going to get to a stop point. But otherwise, you're going to have that elastic end feel. So now we're going to test passive range of movement of the hip into extension. So as a therapist, we're going to stand behind the patient. Our patient is going to be side lying with the testing hip facing upwards. From here, we can ask the patient to straighten their leg out. We're going to take one hand and scoop under, like so. So The kneecap is not being compressed here, and my forearm is just sort of acting as a support for the leg. From here, our other hand is going to block at the pelvis so we don't have an excessive amount of lumbar movement because we're testing the hip. From here, we turn our bodies and just take the hip into more and more extension, taking the opportunity to readjust our step and move so we keep our back safe. So when you're doing this, you want to pay a lot of attention to where the movement's occurring from. And you're going to have to work quite hard at times to fix from someone's hip, but please persist with it because that's going to give you the most accurate range that you want from your hip extension. And that brings us nicely onto our pain, range and end feel. So in terms of pain, the common sites of pain for this, as we just mentioned, lumbar spine, is that the patient can't help but join in and they can't help but contribute a little bit here. So it's not uncommon as you do this for patients to say they're getting pain here. This is likely to be a bit more of a red herring, and if you take the time to really try and isolate the hip extension, you may well find this pain starts to reduce, which will give you a big clue and suggest that actually the pain they're experiencing here isn't directly related to their hip, it's maybe a muscular or a joint lesion here. So that's the first thing. The second common point of pain is going to be on the anterior hip because we're stretching out the anterior structures. So we have a joint capsule in the hip that will be stretched, and we have hip flexors, for instance, that are going to be stretched. So if either of those are irritated, that's going to be referring pain anteriorly on the front of the thigh. In terms of the range, we want them to have 20 degrees. That would be the ideal. You're going to find that the older people get and the more arthritic a hip you see, then it's going to be a bit more restricted. But the more we allow this sort of hip extension to slide and say, well, they're about 15 degrees, that's okay, the more we put our patient at risk of developing lower lumbar problems because they're going to have to use their lumbar spine to produce extra extension. So please take that into consideration when you're formulating your therapy program. With regards to the end feel, this is going to be a more of an elastic end feel as the anterior structures that we talked about before, are being on stretch as we come through. So you're going to definitely have a sort of an area, an element of play where you can feel that elasticity there. It shouldn't be particularly hard. In more extreme sort of osteoarthritic patients, you may find it's a lot of a harder end feel, but that's not going to be absolute in your testing. So you're going to have to put that together with other findings to support a clinical impression of osteoarthritis of the hip. So let's summarize this video on passive range of motion of the hip joint. First, complete your passive range of movement with the patient in a supine position. When completing your passive tests, be aware of your handling for each movement and make sure you compare the affected and unaffected sides. Test passive hip flexion, abduction, adduction, internal rotation, external rotation, and extension. When completing your tests, make a note of pain, range, and end feel. And that concludes our video on passive range of motion testing at the hip joint. From here, we'd like you to compare your passive range of motion findings with your active range of motion findings to see if it's more likely that a non-contractile or a contractile lesion is causing your patient's condition. This, alongside your other tests, will inform the diagnosis. If you're not familiar with why we test active range of motion or passive range of motion, we implore you to look at our videos titled Why Test Active Range of Motion and Why Test Passive Range of Motion for the full clinical reasoning process behind why we do those. Thanks so much for watching, guys. We'll see you again soon on Clinical Physio.